Welcome everyone. In this video we shall be talking about CNS tumors and discuss all the questions related to it. So moving on to the first question. According to WHO CNS 2021 classification, the grading of astrocytoma is primarily based on grading of astrocytoma. MIB1 index? No. MIB1 index is a proliferation marker. Right. The whole classification system is not dependent on a single index. Mitotic activity, necrosis and microvascular proliferation. Yes, the classification does depend on these histopathological finding, but it does not depend solely on the histopathological finding. Right. So that's why B is not our answer. It is also dependent on the IDH1 mutation status, IDH mutation status, right? So answer should be option C, IDH mutation status and histological grade. The histological grade is known as the Saint-Anne-Mayo grading system. Saint-Anne-Mayo grading system, which is dependent on four features. Atypia, mitosis, endothelial involvement and necrosis. Okay. And MGMT promoter methylation status? No, it is not used for classification. This rather tells about the temozolomide response to glioblastoma multiforme. We shall be talking about it. Right. So our grading for astrocytoma depends on IDH mutation status and histological grade. Okay. Moving on to the next question. A 27-year-old presents with seizures and a non-enhancing T2 hyperintense lesion in the temporal lobe. Now, histopathological examination shows the following finding. What is the likely diagnosis? In the histopathological examination, we can see over here the eosinophilic granular bodies. We see eosinophilic granular bodies. Besides that, these are the Rosenthal fibers. Right. The eosinophilic granular bodies and Rosenthal fibers are characteristic of two entities, pilocytic astrocytoma as well as pleomorphic xanthoastrocytoma. Right. So diffuse astrocytoma and subependymal, these are not both eosinophilic granular bodies are not seen in diffuse astrocytoma and subependymal giant cell astrocytoma. Just with this image, we can make out that it is either option A or C. Now remember the fact that pilocytic astrocytoma is seen in children and involves your cerebellum whereas pleomorphic xanthoastrocytoma involves young adults as well as children, and it involves your temporal lobe. Oh my god, I'm so sorry. And it involves your temporal lobe. Okay. But over here we see a 27-year-old, a middle-aged patient, and it involves a temporal lobe. So our answer over here should be pleomorphic xanthoastrocytoma. Just with this histopathological image of eosinophilic granular bodies and Rosenthal fibers, we won't mark the answer as pilocytic astrocytoma. We would read the question. Okay. Moving on to the next question. Identify all the correct associations. Right. This is just a factual question. Pilocytic astrocytoma with BRAF fusion. I'm so sorry. So that's a correct one. Diffuse astrocytoma with IDH1 mutation, that's also correct. Anaplastic astrocytoma with P53 mutation, yes. Subependymal giant cell astrocytoma, NF2 mutation, that's a false statement. NF2 mutation is usually associated with schwannoma, whereas subependymal giant cell tumor is associated with TSC1 and TSC2 mutation, which is associated with tuberous sclerosis. So the answer would be A, B and C. Option B would be our answer. Okay. The certain important thing over here, this classification of astrocytoma, we have pilocytic is based on the histopathological grading, right? For pilocytic astrocytoma, right? None of the histopathological features of the Saint-Anne-Mayo staging, none of the features are present. All the features are absent, right? All the features are absent. For diffuse, your atypia is present. I'm so sorry. Atypia present, but mitosis is absent, right? Then we have anaplastic. Right? We got atypia present, and mitosis absent. And then we have glioblastoma. Right? In glioblastoma, everything is present. Your atypia will be present. Your mitosis will be present. Your necrosis will be present, your endothelial involvement will be present, everything will be present. Okay. Glioblastoma is the grade 4. is grade 4 astrocytoma. Okay, we shall be talking about it. Right. Which of the following differentiates primary from secondary glioblastoma multiforme? Remember the fact that glioblastoma multiforme, which is grade 4 astrocytoma, can be of two types. It can be primary, secondary. Primary is the most common form, and secondary means it arises from a pre-existing low grade astrocytoma. Right? We all know that glioblastoma multiforme is grade 4 astrocytoma. So if there is an pre-existing low grade astrocytoma which converts into a glioblastoma multiforme, we call it secondary secondary glioblastoma. Now, primary is associated with EGFR amplification. Primary is associated with EGFR amplification, whereas secondary is associated with IDH mutation. Okay. So if we talk about the which of the following differentiates IDH mutation, yes, it does differentiate. It does differentiate between them, because IDH mutation is present in secondary but absent in primary. MGMT methylation can be present in both of them, so it cannot differentiate. EGFR amplification, it again differentiates because it is present in primary, not in secondary. And P10 mutation again cannot differentiate. So our answer should be A and C. Okay. Moving on to the next question. Just a second. Extremely sorry for the cut. Right. So moving on to the next question. A 58-year-old man presents with rapidly progressive neurological deficits. MRI brain is shown below. Which histological feature confirms the diagnosis? Histological feature. So this MRI brain shows us this butterfly glioma. This shows us the butterfly glioma. We get the, I'm so sorry. You get the butterfly glioma. Right, butterfly glioma along with rapidly progressive neurological feature, this suggests the diagnosis of glioblastoma multiforme. Right, rapidly progressive neurological deficits along with the butterfly glioma on MRI is very much suggestive of glioblastoma multiforme. Now, the histopathological feature, the characteristic histopathological feature in glioblastoma multiforme is a pseudopalisading necrosis. Okay. If we talk about the other options, perivascular pseudorosettes are seen in ependymoma. Rosenthal fibers are seen in pilocytic and pleomorphic astrocytoma. Right, as discussed above. And calcification can be seen in a lot of other places, like it can be seen in oligodendroglioma, it can be seen in meningioma, it can be seen in craniopharyngioma as well. Okay. Over here, the characteristic histological finding in glioblastoma multiforme would be pseudopalisading necrosis. Okay. Moving on to the next question. Which of the following are true regarding MGMT promoter methylation in GBM? MGMT is methylguanosine methyltransferase promoter. Okay. What it does, it actually increases methylation. When there is increase in methylation, that would lead to DNA suppression. Now, DNA suppression in a tumor cell, is going to inhibit the tumor cells, to undergo any repair, any repair caused by drug. Right. The drug induced damage into the DNA of the tumor cells won't be repaired by the tumor cells if there is increase in methylation. So this activity increases the response of our drug, increases the response of our drugs. Okay. So if we talk about the options, predicts response to temozolomide. Yes, temozolomide is the drug of choice for glioblastoma multiforme. Confers poor prognosis. No, that's a false statement. It would rather be associated with good prognosis. Indicates better survival with radiotherapy. Yes. The treatment of choice for glioblastoma multiforme is radiotherapy plus temozolomide. Okay. It is seen only in secondary GBM. No, that's a false statement. We have just read that this is present in both primary and secondary GBM, glioblastoma multiforme. So our answer would be A and C. Option A. Okay. Moving on to the next question. A diagnosis of oligodendroglioma requires both. Diagnosis of oligodendroglioma. EGFR amplification and TERT mutation, these two are associated with glioblastoma multiforme. MGMT methylation and TRX loss. MGMT methylation is associated with glioblastoma multiforme, whereas ATRX loss is associated with astrocytoma. I'm so sorry for the calls. Astrocytoma. Right. BRAF fusion and P53 are associated with astrocytoma. BRAF fusion is associated with pilocytic astrocytoma and P53 is associated with anaplastic astrocytoma. IDH mutation and P119Q correlation, yes, this is associated with oligodendroglioma. IDH mutation might also be associated with astrocytoma, but this co-deletion of 1P19Q is very much characteristic of oligodendroglioma. Okay. Moving on to the next question. A 40-year-old patient presents with long-standing seizures. CT shows a calcified lesion in the frontal lobe. Right, and histopathology is shown below. What is the most probable diagnosis? You can very well appreciate these cells, right? We can get a round nucleus. We get a round nucleus with perinuclear halo. Right? And this is suggestive of a fried egg appearance. This is suggestive of fried egg appearance. And we can also appreciate this branching capillaries, right? This is known as chicken wire vascularity. Okay, and these two features are very much characteristic of oligodendroglioma. Okay, moreover, the CT also showed a calcified lesion. This calcified lesion is also suggestive of oligodendroglioma. Okay, so our diagnosis over here would be oligodendroglioma. Okay, moving on to the next question. Which of the following about ependymoma is correct? Associated with NF2 mutation, that's a false statement. It is associated with NF1 mutation. Very rarely might be associated with NF2, but I would consider option A to be incorrect. Found in fourth ventricle and spinal cord, that's a true statement. It arises from the ependymal cells. Okay. Spreads via CSF. Yes, that is also a true statement. This is known as the drop metastasis. This is known as the drop mets via CSF to the spinal cord. And shows GFAP positivity. That is also a true statement. Remember that GFAP positivity is seen in astrocytoma, is seen in glioblastoma, is seen in oligodendroglioma, is seen in ependymoma. It is seen in choroid plexus tumor and also seen in medulloblastoma. Okay. So our answer over here would be B, C and D. Option C would be correct. Okay. Moving on to the next question. A 6-year-old presents with truncal ataxia, hydrocephalus and a midline cerebellar mass. Histology is shown below. What is the most likely diagnosis? In the histology, we can see the small blue round cells, and we can also appreciate the Homer right rosettes, right? Remember the fact that a CNS tumor with small blue round cells and Homer right rosettes is without doubt medulloblastoma, right? It can be nothing but medulloblastoma. Okay, we get a cerebellar mass, right? A cerebellar mass with these features in histology is without doubt medulloblastoma. Right. Moreover, remember the fact that medulloblastoma usually involves your cerebellum. The most common site is cerebellum, and it involves the vermis of cerebellum most commonly. And moreover, it involves a child, right? It is more common in a child. So 6-year-old is suggestive of medulloblastoma. Remember that this small blue round cell tumor can also be found in neuroblastoma. Can also be found in Ewing's sarcoma. Can also be found in retinoblastoma. Okay. So moving on to the next question. A child presents with cerebellar ataxia. CNS tumor was suspected and MRI was done, which is shown below. Which of the following statements about the diagnosis is incorrect? Right, and MRI also shows a mass in the cerebellum, right? So this will be medulloblastoma again. Because medulloblastoma is the most common CNS tumor, is the most common malignant CNS tumor in a child. Okay. Moving on to the options. Read which of the following diagnosis is which of the following statements of the diagnosis is incorrect, right? Associated with Charcot syndrome, that's a true statement, right? Not only Charcot syndrome, it is also associated with Gorlin and Li-Fraumeni syndrome. Li-Fraumeni is associated with P53 mutation. Okay. Drop meds is yes, drop meds are evident, right? Again via CSF to the spinal cord, via CSF to the spinal cord. Always considered a grade 4, that is also a true statement, right? There is nothing called grade 1, 2 or 3 medulloblastoma. Medulloblastoma is always a grade 4 tumor. And HP shows angiocentric growth and hooping pattern. That's a false statement, right? We have read that the histopathology is going to show us these homocyte rosettes and small blue round cell tumor. Right, we get this angiocentric growth and hooping pattern in CNS lymphoma, or rarely in ependymoma. Okay. Moving on to the next question. A 45-year-old woman presents with headache and focal seizures. CT finding is shown in the image below. Histology shows whorls and psammoma bodies. What is the likely diagnosis? You can very well appreciate over here a mass and is extradural, right? It is an extradural mass. We see calcification being present, and our histopathology shows psammoma bodies. Everything is suggestive of meningioma. Remember that a CNS tumor with psammoma bodies is almost always a meningioma. Our answer would be D, meningioma, right? And this arises from the meninges. We can very well appreciate that it is arising from the meninges from the CT image, and this presentation in a middle-aged woman. Remember the fact that CNS meningioma usually presents in middle-aged women. Okay. Psammoma bodies besides meningioma, right? This psammoma bodies besides meningioma can also be seen in papillary thyroid cancer, can also be seen in the papillary variety of renal cell carcinoma, can also be seen in serous cystadenoma or cystadenoma of ovary, right? So moving on to the next question. Which of the following are associated with meningioma? NF2 mutation, NF2 gene mutation on chromosome number 22. That's a true statement. Remember that meningioma is associated with both NF1 and NF2 mutation. Okay, mutation. Excuse me. Radiation exposure, yes, for meningioma it is a very important risk factor. Radiation exposure is a very important risk factor in meningioma. Progesterone receptor positivity, this is also a true statement. That's why females are affected more than that of males. And loss of 1p19q, this co-deletion as we already discussed is associated with oligodendroglioma. So this is a false statement. So our answer should be A, B and C. Option C should be correct. Okay. Moving on to the next question. A 32-year-old man presents with unilateral sensorineural hearing loss and imbalance. MRI finding is shown in the image below. What is the likely diagnosis? The MRI finding you can very well appreciate. This is the ice cream cone appearance. This is the ice cream cone appearance, right? In the ice cream cone appearance in cerebellopontine angle, right? Then this ice cream cone appearance in cerebellopontine angle is suggestive of vestibular schwannoma. And vestibular schwannoma involves the 8th cranial nerve, right? And from this clinical picture, we can very well see that it is causing unilateral sensorineural hearing loss and imbalance, which is nothing but CN8 involvement. Okay. So our diagnosis would be schwannoma. Option A. Okay. Moving on to the next question. A 35-year-old patient presented with sensorineural hearing loss and difficulty to maintain balance. Image shows a mass in the cerebellopontine angle. Everything over here is again suggestive of schwannoma. Histopathology of the lesion is shown in the image below. Which of the following is not true about the diagnosis, right? These things are known as the Verrucke bodies. Right? And Verrucke bodies are characteristic finding in a schwannoma, right? Which of the following is not true about the diagnosis? Shows GFAP positivity. No, GFAP positivity is not shown by schwannoma, right? They are seen by a lot of other CNS tumors. We have just discussed a few questions ago, but is not shown by schwannoma. Rather, schwannoma shows S100 positivity. So our answer would be A. Let's have a look at the other options. Encapsulated and eccentric to the nerve. Yes, that's a true statement, right? Schwannoma is encapsulated, right? And shows antennae in, yes. This is again another histopathological finding in schwannoma. we get the antennae A areas which are densely packed cells, and antennae B areas which are loose myxoid cells, right? This image focuses on the antennae B area. Antennae A area is not shown in the figure. In antennae A area, we would get densely packed cells. And bilateral lesions are seen in NF2. That's a true statement, right? In NF2, we get bilateral lesions. Over here, option A would be our answer. With this, we come to the end of our discussion on CNS tumors. If you like this video, consider subscribing to my channel, and thank you for watching.